Hello everyone, I am Dr. Raina Tembey, and in today's lecture we shall be having a look at few variants that we see while reporting our MR angiography. We shall identify the variations in the circle of Willis, neck angiography, and have a look at few persistent carotid-basilar anastomosis. Let us start by identifying the origin of arch vessels. Normally, there are three vessels which arise from the aortic arch: the brachiocephalic, the left common carotid, and the left subclavian artery. In this case, we can see that there are two branches arising from the aorta. The first is the common trunk, which then divides into the brachiocephalic and left common carotid artery, and the second is the left subclavian artery. This is the most common variant that we see in our routine practice. Sometimes we see an aberrant right subclavian artery origin in which the right subclavian arises as a separate branch from the aortic arch. As we can see in this case, this is the aortic arch, and as we scroll through the images, we can see that there are four vessels which arise from it: the right common carotid, left common carotid, left subclavian, and the artery arising distal to the origin of left subclavian is the right subclavian artery. It then reaches to the right side by coursing either posterior to the esophagus or between trachea and esophagus or anterior to the trachea. We have here a mid-coronal image of the same patient, and we can identify the right subclavian artery which is arising directly from the aortic arch and then coursing towards the right. In the next case, we are going to see the left vertebral artery arising directly from the aortic arch. So we have here our source angiography images, the aortic arch, and as we scroll through the images, we can see that there are four vessels which arise from the aorta. They are the brachiocephalic, left common carotid, left subclavian, and we can see the left vertebral artery arising directly from the aorta. It is diffusely small in caliber and it is hypoplastic. We shall have a look at this on the neck sagittal images as well. We have here a neck sagittal image, and we can see this is our left vertebral artery which arises directly from the aortic arch. One of the rare variants that we see is when the left vertebral artery arises from the left common carotid artery. We shall see this in our next case. So we have here the aortic arch, and as we scroll through the images, we can see that there are three vessels arising from it: the brachiocephalic, left common carotid, and left subclavian artery. So as we go further, we can see that there is a small branch which is arising from the left common carotid posteriorly. This is the left vertebral artery. The left vertebral is hypoplastic even in this case. Now we shall go to the sagittal images. These are the sagittal neck angiography images, and we can see the left common carotid artery here, and the branch arising posteriorly from the left common carotid artery is the left vertebral artery. So we are tracing the left vertebral artery and we can see that it is hypoplastic. Now we shall have a look at the circle of Willis variant anatomy. The circle of Willis is formed by the terminal internal carotid and basilar artery, the A1 segment of ACA, P1 segment of PCA, and the anterior and posterior communicating arteries. Hypoplasia or aplasia of its component parts is very well known. We shall first have a look at the ACA variations. The first variation that we shall see is the absent A1 segment. So in this case, we can see the right A1 segment. The left A1 segment is absent. Sometimes the A1 segment is diffusely small in caliber or hypoplastic. As in this case, we can see that the right A1 segment is normal in caliber, but the left A1 segment is hypoplastic. The next case we will see the ACA can be fused proximally to form a single trunk or the azygous artery. So we can see in this case that the two ACA segments are fused proximally and they form a single trunk which runs between the cerebral hemispheres. This is the azygous artery. When we have a look at it on the sagittal images, we can see that there is a single trunk in the interhemispheric region and it divides near the genu of the corpus callosum. The next variant is a bihemispheric ACA in which one of the A2 segments is dominant. As we can see, the left A2 segment is dominant and the right A2 segment is hypoplastic. So in this case, the left A2 segment will be providing major arterial supply to both the anterior cerebral vascular territories. The next variation is a fenestration. As we can see in this image, there are two A1 segments on the right. They have a parallel course, they have a common origin and they converge distally at a common point. This is the fenestration of A1 segment. In trifurcation of ACA, we see there are three A2 segments. We shall scroll through these images now. We see our A1 segments and these are the A2 segments. So as we scroll through these images, we can see that there are three A2 segments in the interhemispheric region. So this is the trifurcation of ACA. When we have a look at it on the sagittal images, we can easily appreciate the three A2 segments. The common middle cerebral artery variant that we see is when there is early bifurcation of the MCA. We can see that the M1 segment is short and it bifurcates close to its origin to the ICA. This is the early bifurcation of MCA. We shall have a look at the posterior circular variation now. Sometimes the vertebral artery is small in caliber and it terminates by giving rise to the posterior inferior cerebellar artery. So in this case, we can see that the right vertebral artery is smaller in caliber as compared to the left. It is giving rise to the posterior inferior cerebellar artery and then terminating. The left vertebral artery is continuing to form the basilar artery. The next case is of a fetal origin of posterior cerebral artery. We can see here the internal carotid arteries and the basilar artery termination and the right posterior communicating artery arising from it. On the left, there is a very small branch that is the hypoplastic or undeveloped P1 segment of the left PCA, and we can see that the rest of the PCA is being filled exclusively by the ICA via the posterior communicating artery. This is the fetal origin of the PCA. Let us now have a look at few persistent carotid-basilar anastomosis. The most common anastomotic pattern that we see is that of a persistent trigeminal artery. Let us identify this vessel in our case. We have here the internal carotid arteries and the basilar artery. As we scroll through the images, we can see that there is a branch which arises from the ICA immediately after its exit from the carotid canal and anastomosis with the mid-basilar artery. This is the persistent trigeminal artery. We shall have a look at it again on the coronal images. So we have here the internal carotid artery on the left. So as we scroll through the images, we can see a branch which arises from it and it anastomoses with the mid-basilar artery. We can see that the basilar artery that is caudal to the anastomosis is hypoplastic. The second most common variant that we see is the persistent hypoglossal artery. It originates from the ICA at the level of C1 through C3 vertebral bodies. So let us trace this vessel now. We have here the internal carotid artery on the left. We shall follow this vessel. As we scroll through these images, we can see that there is a branch which arises from the ICA at the level of C1 to C3. It traverses through the hypoglossal canal and it anastomoses with the basilar artery. This is the persistent hypoglossal artery. On the coronal images, we can see the persistent hypoglossal artery anastomosing with the basilar artery. In today's lecture, we have seen some of the common variants that we see while reporting our routine MR angiography. It is important to make a note of these variations in our reports as they can be clinically significant in case of infarct, hemorrhage, or when any intervention is planned. Thank you.